Hey guys, welcome to the renal chapter. My name's Nick, and in this section of the chapter we will be discussing the embryologic process of nephrogenesis. It's a progression from one bizarre term to the next, but don't get your ureters in a twist, because we're going to break this down into the logical, stepwise process that it is. As we go through this section, I'll point out some high-yield subjects, discuss what can go wrong in the developmental process, and explain the main role of the fetal urinary system, which is to do what? Correct. Produce urine to supplement the volume of amniotic fluid. So with that, let us flow on down to renal embryology. The kidneys are derived from intermediate mesoderm, which is also known as the nephrogenic cord. The mesoderm is what supplies the meat of our body's final form. Now quickly, what else do you know that originates from the mesoderm layer? Muscle, bone, connective tissue, and a handful of other important anatomy that will be discussed further in the reproductive chapter. Now, the nephrogenic cord spans from the cervical to the sacral regions of the developing fetus, eventually giving rise to the three stages of the fetal kidney: the pronephros, mesonephros, and metanephros. The pronephros exists in the cervical region and will eventually degenerate during week 4 of development. It is non-functional during fetal life and will not form any adult remnant. Once the pronephros degenerates, the mesonephros will form and function as a temporary kidney for the first trimester. Now this is a key concept and is often tested on boards. The mesonephros, although transient, is the first functional unit of the fetal kidney. Each tubule has its own glomerulus, from which these tubules will filter blood and produce urine, therefore adding to the volume of amniotic fluid present in the uterus. Although its role as the fetal kidney is brief, the mesonephros will continue on to serve a purpose elsewhere. Can you think of one other structure it gives rise to? The vas deferens. And what does this structure do? Well, the vas deferens transports sperm from the epididymis to the ejaculatory duct. This is partly why the pelvic anatomy is often referred to as the genito-urinary system, due to their close proximity and common embryologic origins. In this way, any pathology associated with the mesonephros might also affect the function of the male reproductive system. This concept of one organ system's defects affecting a different organ system's function is commonly tested on step 1, so let's keep that in mind as we move on. The metanephros first appears in the 5th week of gestation and will develop into the permanent kidneys. The metanephros is essentially derived from two separate structures. Do you know what these structures are? They're ureteric bud and metanephric mesenchyme. Now this mesenchyme may also be referred to as the metanephric blastema or the metanephric mesoderm in some texts, but to stay consistent with first aid, we'll call it the metanephric mesenchyme during this lecture. Let's take a look at another image so we can break it down a little more. Now this image is actually taken from the first aid text, so you've probably seen it before, but repetition is the key to adult learning, so let's go through it one more time. As we can see, the pronephros has degenerated, and this happens when? Awesome. Week 4. Further down, we see the mesonephros, the kidney that functions during the first trimester and later contributes to the male genital system. Finally, we see the metanephros, being formed from two structures: the ureteric bud, abbreviated here as UB, and the metanephric mesenchyme, MM. The ureteric bud, which will give rise to the tubing of the kidney, includes the ureters, pelvises, calyces, and collecting ducts, and it's actually derived from the caudal end of the mesonephric duct. It extends laterally to join with the metanephric mesenchyme, thus forming the metanephros. Now this interaction is paramount, and any abnormalities in signaling or development can result in severe congenital malformations. For example, one of the many transcription factors involved in this process is WT1. This transcription factor is actually sent from the metanephric mesenchyme to the bud during development. Abnormalities in this transcription factor are linked to an increased risk for the development of the most common renal pediatric cancer. Do you know what this cancer is? Wilms tumor. We'll talk a little bit more about Wilms tumor when we get into renal path. Now, the ureters develop as solid cords and are canalized later in development. The ureteropelvic junction, or the UPJ, which is where the ureters connect to the renal pelvis, is the last to canalize and therefore the most common site of failed canalization. This leads to obstruction of urine flow and hydronephrosis. Flash quiz, here we go. What adult structures in the urinary tract are derived from the mesonephros? The collecting ducts, calyces, pelvises, and ureters. Remember, these are all formed from the ureteric bud, but the ureteric bud is actually an extension of the mesonephric duct. As we discussed in the beginning of the section, the main role of the fetal urinary system is to produce urine. This urine supplements the volume of amniotic fluid. If the volume of amniotic fluid drops too low, the fetus may fail to develop properly. Potter's sequence, or syndrome, is a consequence of having too little amniotic fluid present in the uterus. This lack of amniotic fluid is actually called oligohydramnios. A sequence is actually a type of error in morphogenesis. It describes a set of abnormalities resulting from a primary embryological event. Now, in Potter's sequence, what do you think that primary event is? Well, it's oligohydramnios. Everything stems from the fact that there's just too little amniotic fluid present in the uterus. Can you think of any other sequences? Well, one that comes to mind and is often tested on step 1 is the Pierre-Robin sequence, characterized by the triad of macrognathia, or the presence of a small mandible, glossoptosis, posterior displacement of the tongue, and cleft palate. Now, breaking down the roots, oligohydramnios literally means few water in the amniotic sac. With too little amniotic fluid, the fetus suffers from compression by the muscular uterus. As you can see in the picture, which represents a normal amount of amniotic fluid present around the fetus, the fluid prevents the mother's uterus from compressing down onto the fetus. However, if there were too little fluid, this compression could lead to limb deformities, facial deformities, and pulmonary hypoplasia. The pulmonary hypoplasia occurs because fetuses in utero normally swallow amniotic fluid into their lungs. This helps to expand the alveoli and develop their lung tissue. If there's not enough amniotic fluid, the lungs will not develop properly. Pulmonary hypoplasia is thus the primary cause of death in infants with Potter syndrome. Can you think of some possible causes of Potter syndrome? Autosomal recessive polycystic kidney disease, posterior urethral valves, and bilateral renal agenesis. So what's the common theme among all these conditions? Correct. The inability of the fetus to produce urine, which leads to oligohydramnios. In contrast, polyhydramnios is associated with too much amniotic fluid present in the uterus. Polyhydramnios is associated with certain fetal malformations such as esophageal or duodenal atresia and anencephaly, both of which result in the inability of the fetus to swallow the amniotic fluid. Remember, the fetus must swallow the amniotic fluid so that the lungs can develop properly. If no swallowing occurs, excess amniotic fluid will accumulate in the uterus. Next, let's talk about horseshoe kidney, the most common congenital renal anomaly and therefore often tested on step 1. During development, the kidneys rise from the pelvis until they reach their final position around which vertebral level? Very good. T12 to L3. I remember this by repeating the phrase, 1, 2, 3 is where you find kidneys, the 1 and the 2 representing T12 and the 3 representing L3. A little odd and kind of goofy, but maybe goofy enough for you to get that point on the exam. Now, in normal anatomy, which large anterior branch of the aorta do the kidneys lie next to? Correct, the superior mesenteric artery. The renal vessels actually pass under this artery. However, if the kidney's inferior poles fuse before they ascend, they get trapped under the inferior mesenteric artery. This condition is commonly associated with what genetic abnormality? Very good. Turner syndrome. Now quickly, what are some other characteristics of Turner syndrome? Well, you have the exokaryotype, short stature, lymphatic defects resulting in a webbed neck, bicuspid aortic valve, coarctation of the aorta, and ovarian dysgenesis leading to amenorrhea. Turner syndrome will be discussed in much further detail in the reproductive chapter, but we want to keep in mind the association it has with horseshoe kidney here. Next, multicystic dysplastic kidney, which is caused by the abnormal interaction of which two embryologic structures? Correct, the ureteric bud and metanephric mesenchyme. This leads to a non-functional kidney consisting of cysts and connective tissue. Remember, the ureteric bud interacts with the metanephric mesenchyme to induce proper nephron and glomerulus formation. If it's unilateral, it's generally asymptomatic because the contralateral kidney can compensate via hypertrophy. However, a bilateral case would be incompatible with life. An important point to keep in mind is that this is a non-inherited disorder. We'll talk about the inherited cystic renal disorders during the renal path section. Alright, flash quiz, here we go. If a female presents with primary amenorrhea and a karyotype of 45X, what renal anomaly should you expect? Well, this is horseshoe kidney seen in Turner syndrome. This is when the kidney has fused inferior poles trapped under the inferior mesenteric artery root during their ascent from the pelvis. To finish up this section, let's discuss how one kidney can end up with an extra route for urine outflow. As we mentioned before, the ureteric bud is going to grow laterally from the mesonephric duct, seen here, ureteric bud seen here, metanephric mesenchyme seen laterally. The bud will grow laterally, and once these two form, this, as you already know, will make the metanephros. However, in a similar situation, where the bud grows laterally, but then bifurcates, or splits, prior to reaching the mesenchyme, this is going to create two separate routes for urine outflow, and thus two separate ureters in the final form of the kidney. Alternatively, a duplex collecting system can also occur when two totally separate ureteric buds reach and interact with the metanephric mesenchyme, as you see here in the image. So these two ureteric buds did not come from a bifurcation or splitting. They originated all on their own, so they're going to form two separate ureters in one kidney. The duplex collecting system has a strong association with vesicoureteral reflux and increased risk for subsequent urinary tract infections or UTIs. Now, generally speaking, what urinalysis tests are used to diagnose a UTI? Good. The leukocyte esterase test and the nitrite test. In the microbiology chapter, we learned that a positive leukocyte esterase test represents the presence of bacteria, whereas a positive nitrite test is more specific for gram-negative bacteria, the most common type of bacteria in UTIs. Vesicoureteral reflux happens due to bladder wall expansion and an incompetent vesicoureteral valve. Normally, the ureter opens into the bladder at about a 45-degree angle. Once the bladder expands with urine, there is a valve that closes off, preventing urine from entering the ureter and preventing infection from occurring. However, if there are two ureters opening into the bladder on the same side, the bottom ureter is going to open at an odd angle, so that when a bladder expansion occurs with urine, the top valve is still working, but the bottom valve is incompetent, predisposing this ureter to infection and vesicoureteral reflux. Due to the abnormal vesicoureteral angle, the valve will remain open and predispose the system to eventual infection. Alright, let's finish it off with a board-style question. A baby boy dies several hours after his birth despite several attempts to save his life. He was born with wrinkled skin, deformed limbs, and abnormal facies. Prenatal ultrasonography at 15 weeks indicated that the mother's pregnancy was complicated by oligohydramnios. Which of the following embryologic processes most likely failed in this child? Correct answer is B, the development of the ureteric buds. Alright folks, that's all for renal embryology. See you next time.